Good evening and welcome to Imperial Lates Online on Healthcare Heroes, the latest in our new public event series exploring research at Imperial College London. My name is Maxine Myers. I'm the Communications Manager for Imperial College Academic Health Science Centre, and I sit within the college's research communications team. And my role involves showcasing and communicating the research conducted by our academics within our faculties and how we work with our NHS partners to develop new tests, new treatments and new devices for patients within NHS hospitals and wider to benefit from. This week's late programme has looked at the heroes of healthcare, from bedside and COVID frontlines to research laboratories. And tonight we are going to be discussing a new age for the NHS, looking at what we can learn from the outbreak and take into a smart and brighter future when we care for our nation. Before I introduce my guests, we've got three fantastic speakers. I wanted to remind you all watching at home that this is an interactive event. So please do send us your questions and thoughts. One of our team working away in the background, commenting on and monitoring the YouTube chat, and will be passing on your comments to me so that I can read them out and put to our guests. Also, before we start, could I just ask everyone to be considerate of others when you are posting the live chat? We want to create a positive, welcoming space for this online conversation, which I'm no doubt will be really engaging, informative and insightful. So we just want to create a really positive space for this stimulating conversation and debate. So with that in mind, we will be removing any comments that are explicit, offensive or disrupt the flow of the event. So if this is all understood, let's meet our guests joining us tonight. So firstly, I'm going to introduce Professor Sonia Saxena. Sonia is Professor of Primary Care and Head of Child Health at School for Public Health at Imperial College London and a practicing GP over the past 25 years. Sonia combines practice as a GP in the South London community with research in what primary care and public health policy can do to improve child health by unlocking the information held in routine NHS and health data that captures day-to-day practice. Hi, Sonia. Welcome. Secondly, I want to introduce Anna Bakobza. Anna is the Director of Integrated Care at Imperial College Healthcare NHS Trust. Her work over the last 6 years has focused on the development and testing of new models of health and care delivery that dissolves the traditional boundaries between hospitals, primary, community care, mental health and social care. Hi Anna, welcome. And last but in no means least, I would like to introduce Ivor Williams. So Ivor is a designer. He leads the End of Life Care Group at the Institute of Global Health Innovation at Imperial and the Helix Centre, at Imperial College London. He leads cross-functional teams of designers, developers, academics, clinicians, and policy analysts tackling complex health and care challenges using digital design. He also previously co-founded the mental health startup, Humane Engineering, and created the NHS-approved music therapy app, Code. So welcome to you all. As you can see, we've got three fantastic speakers with a range of expertise from primary care design to integrated care. So I'm sure this will be a really stimulating conversation. I will kick things off and pose a question to you guys first. So my question to you all is, lots of the future of care conversation is focused on digital developments, such as AI to diagnose a range of conditions. How do patients benefit from these technologies? And how do you ensure using these technology doesn't mean that the human side of delivering care isn't lost? I'll give you first, Sonia. Sorry, Sonia, can you hear me?
So, sorry, what, are you asking me?
Yeah, I'll start with you first.
Sorry.
No.
So, great question. How does the future of care conversation, how patients benefited by technologies that we've seen? I think the biggest advance that we've had to rapidly adapt to in recent times has been communication with patients. So I think that the whole world has suddenly learned how to speak to each other down small screens, and we've definitely had to do that with remote consulting. But even before that, we had already started to move our systems, particularly in primary care. I'm a general practitioner, so out in the community, we have had artificial intelligence where we have alerts that pop up that remind us to do a number of things and automate things that help us to do our job better. So in the old days, we used to have to take the old Lloyd George records down and sift through patient notes and see how many patients we'd missed for asthma medications or cardiovascular therapies. And then around the sort of 90s and 2000s, we started to computerize. So we've seen a huge expansion in much more intelligent checklisted systems that keep us in track and free us up from missing things. The downside of that, of course, is that patients sometimes complain that we spend an awful lot of time staring at computers when they have time in the consulting room. It's another person. And sometimes when you have video consulting, you have a number of people that bring together, but some of that magic is lost for patients. So that empathic sense of being present in the moment, we have to be very mindful of that. There are a number of things that I could say that we really have found very helpful. So monitoring at point of care has been a real advance for us, being able to strap monitors on for blood pressure to get patients to really feel very empowered by being able to send their observations down the line without having to be transported to hospital or coming into the surgery. That's been terrific. Prescribing, amazing, really, really helpful. All that ridiculous printing of paper for people to queue up by the reception, take their green prescription round to the pharmacy. We just, it's all done with a click now. So benefits have happened. It's really improved safety as well. So a really good example of that is getting investigations in a timely way, and of course the electronic care record. And on top of that, the research that my teams and other people do that will that has actually improved the science around how we do this. And a brilliant example from Imperial NHS Trust is my colleague Kate Honeyford and others who've led sepsis alerts. So they set them in silent in the background, and when they turn them on, it has genuinely improved death rates. It's improved survival for patients coming in with sepsis. But of course, it benefits some patients and not others. And that can actually sometimes create problems and widen inequalities. So I think we just need to be very careful about how we go forward and try and keep the things that technology has shown us that are really valuable and bolster those up.
And it's like you said, like a lot of this technology that's been in the work for a number of years, and I guess this pandemic has really made us have to integrate things and adapt things a lot quicker. Anna, do you have any thoughts yourself from your experience within the trust in terms of how you integrate this technology, but then also keep the sort of the human side to care?
So I think the point I would make is that all healthcare professionals of all different flavours and backgrounds are learning through doing, just like all other professions that have had to rapidly digitize what they're doing. I think about my primary school aged children whose teachers have had to totally change the way that they teach. It's no different for our healthcare professionals who were maybe a little way forward than teachers were 6 months ago. But I'm very conscious that my clinical colleagues are learning through doing. And I think we've all got to be very mindful, both as practitioners and managers and patients on the receiving end of this care conversation, that this is a very new way of working, and we've all got to be quite sort of kind to each other, I think, in acknowledging that. But ultimately, this is a care profession with human contact at its core. and the rapid transition to virtual platforms isn't going to be completely bump-free. I think what I've heard from clinical colleagues of mine and from patients is that the human contact is needed by both sides. I think doctors, I don't look to Sonia, I guess, for a reaction on this, but I feel like doctors miss the human contact with their patients just as much as some patients miss the human contact with their doctors, nurses, and other healthcare professionals. So I think it is really, really important that for the delivery of compassionate care, whether personal in person or virtually, we keep that at the core of what we're supporting our healthcare teams to deliver. And part of your question, I think, was about ensuring that that human side is retained where possible. Well, how do we do that? Well, I think there's something about risk segmentation and prioritizing the now scarce face-to-face capacity that we do have for the cases that need it most. I don't know that we are completely slick on how that segmentation should be done, but clearly we have less face-to-face capacity than we used to have, and therefore a set of decisions needs to be made.
And Ivor, I think it was quite interesting, Anna's talking about learning lessons. I mean, from your perspective as a designer, what do you think it'd be interesting to hear your take on how do we integrate this technology but ensure that we still keep the human side of care?
Yeah, I mean, I think from my position as someone who's actually doing the designing of the technologies and trying to find their place in these systems is really to make sure that any technology is augmenting the work of a healthcare professional or a care professional. There's really no replacement. You can't digitize compassion, as Anna's kind of pointing out, and that kind of the role of care and healing is irreplaceable. So I think the thing for me as someone kind of tinkering with on that side of the healthcare system is how can the technologies that we're using and are still very much maturing. The basics of internet in healthcare trust is still problematic. The real the infrastructure stuff is still hard to get sometimes. So how does that kind of just speed things up? But then when you start to get to the newer technologies, how does that personalize the experience for a patient or their family? How does that support the healthcare professional to be with that person as much as they can without kind of getting lost in clunky interfaces and ways of working, which is detracting from the core job? All those are kind of really important elements. And I think the larger part is how, from my perspective, how healthcare professionals can help create the solutions as well. So it's not simply a matter of me coming in and saying, okay, we're going to fix your problems. It's like, how can these solutions be co-created? How can they be responded to in the ways that a doctor and nurse can create the tool that they need to get their job done and done well.
So it's the case of working closely with doctors, nurses, and the patients to create technologies that beneficial both sides then, and getting that input's vital.
Absolutely.
Something like we talked about the pandemic and some of the answers. We talked about how the NHS adapted quickly to the rise of coronavirus cases, but then that came at the expense of the delivery of some key services, notably cancer services, for example. As we're heading into winter, we're heading into flu season, a potential resurgence of cases. How do you think we deal with treating coronavirus cases, but ensuring that key services still remain, that NHS services, the NHS remains open for business despite COVID? Anna, have you got any thoughts?
This is something that keeps the senior leadership of our trust awake at night. Genuinely, it's deeply, deeply worrying, I think, to all of us in the system. The level of risk that's being carried in those waiting lists is something of great concern. So what are we doing? Well, some very careful prioritization, case by case, patient by patient prioritization based on the clinical risk. I think part of the solution for this will be allowing health and care providers to play to their strengths rather than their traditionally commissioned services. So, for example, in North West London, we're looking, or we have been looking for many years, but this is giving us the burning platform, I think, to sort of seal the deal, as it were, consolidation of what we would think about as high volume, low complexity procedures. So let's think about hip and knee replacements, for example. We do lots and lots of them every year. Does it make sense for every hospital trust to be doing that, or ought we consolidate that activity and capacity in one place? So we're looking at different ways of sharing out the provision of different types of services to allow providers to make the best use of their resource and to play to their strengths. Another example, these things are very politically sensitive, but, pediatric surgery, for example, that's the opposite. It's high complexity and low volume. Do we need 3 different providers to be doing that across North West London, each with relatively small practices, or is it more appropriate for one provider to be really super specialized in that area? One imagines that the outcomes for those children undergoing surgery might be better if those surgeons are doing greater volumes and getting more practice, as it were. So I think there's something about clever use of the resource that we've got, and also, again, politically sensitive, but clever use of the private sector. We have in the NHS had some regional deals done with independent sector providers. I think we're still learning how to use that capacity, and I think in the event of any future waves, that capacity and potentially different use of the setup of the Nightingale Hospital, which was a heroic thing that was built overnight, but possibly not used to its fullest potential. So differential use of the space that we've got, both in the current hospitals, in the independent sector, and in anything new that's built.
So it's about greater collaboration, potentially, with partners, other hospitals within North West London, and potentially the private sector, and just seeing how that could work in terms of a potential second wave of cases. Sonia, I'd be interested to get your take on this, your perspective especially as a GP. What are your thoughts?
I think that we're all worried, as Anna says, about the non-COVID related disease burden growing. That backlog is appalling. I'm starting to see people who are empowered to come in. I mean, I have to remember that in the first few weeks, in January, we had 90% of contacts in general practice were face-to-face. That fell to 1 in 10 in those first early weeks and hasn't recovered. So we're seeing about half and half. In some practices, there's huge variation. It's about a third now. So we're managing an awful lot remotely, but a lot of the services that were fully deprioritized, there's a big backlog that's come. I saw somebody yesterday whose wife melted into tears because she's just been really worried about his slow deterioration. They've been afraid to come. He's elderly. And he may have a recurrence of his cancer. Now, when they left seeing me, they sailed out. They felt the relief of, even if it is something, at least it will be detected now. We've come, we've had it addressed. But I can do that because, we have seen that there is a bit more capacity currently in our waiting rooms, but that's going to change. We're starting to see it build up. My husband works in a local acute trust, and they're opening a new ward each day to cases. So it is coming. Be absolutely clear about that. We are going to get again up to capacity. And I agree fully with Anna that we have to be very smart about separating clean continuing non-COVID related cases. At the beginning of the pandemic, we had hot sites, and I think we really do need to think about whether at what stage we need to then staff those again. And we also need to engage the public now. They've learned we've all learned an awful lot. So there's a huge opportunity, and I think technology is part of that solution as well. Those who are digitally literate and those who can be trained to really do a lot more for themselves and help us to sort of separate out so that we can continue to operate safely in clean spaces. We can think of ways, I mean, if we can get the testing sorted, then I think that would help us all enormously. But anyway, it is politically charged. I don't want to be drawn into critique because we will just use up all of our time. But we're all doing what we can. We really are. And the public have been brilliant, but we've got to keep them on board. And actually, what's really sad, and I wrote about this at the beginning as well, is that, you know, families have been really marginalised. There are women who are delivering their babies and don't have access to their normal social capital that they would have. They're really cut off. Rates of postnatal depression have gone up. It's hard enough, as many of us know, to raise a child in normal times, but it's been really devastating and difficult, and plus then having to deal with children when they get sick has been really problematic. But visits to emergency departments went down by 90% in those first early weeks. So I think there's an awful lot of fear, and we just have to help everybody learn how to live with this thing and move forward. Otherwise, we're never going to get anywhere.
So do you think it's a case of, especially picking up on your point about that fear, I remember doing stories during the height of the pandemic, talking about admissions to A&E very low, people scared to go to their GP for because they're worried about both bed and the NHS. Do you think we need to do a bit more around, you know, really saying to people that if you do have concerns or conditions, you need to see your GP, that you should visit your GP? Is there more to be done, especially as you're saying, like we are heading towards a second surge now, and that could, you know, that was an issue that came up first time round, it potentially could come up second round.
I personally think that that's very important. The signposting has been stay at home, protect the NHS, save lives, and that was fine for the first few critical weeks. But we do need to say, you must come. If your child is sick, worried, you must get in touch, and you know, we are here for you. We've been open all the way through. I mean, earlier last week, the NHS England thought it was a helpful thing to do to write to every GP. You may have heard about this, reminding us that we'd be in breach of contract if we didn't invite patients in. People are confused. We have never stopped offering face-to-face appointments. People have stayed away because they followed the guidance, but they need to now be in a situation where they know the government has to tell people what they can come for and what they can't come for. And the NHS signposting has not been very clear at all. And there's still, you know, if you're very digitally literate, you might just about be able to navigate that. But people don't know whether, if they've got a few cough and cold symptoms, whether they should be isolating, and there isn't the support out there. So we need much clearer signposting that the services are open, the services are available for patients, but we also do need to be very mindful of the fact that as things mount up, you know, can we cope? And are there ways that we can alleviate that burden? Because just before the lockdown, I published a paper looking back over the last 10 years, and we've seen rates of health contacts with GPs, but also emergency departments, admissions, across the board. Contact rates have been rising year on year, and there's all sorts of reasons for that. You know, we do more for each individual condition. It's an aging population, so there's a growing burden of disease. Patients demand more. We need to make sure that the care we offer is safe. But I really think that we need strong solutions to signpost the right people to the right places.
Yeah. And Ivor, just picking up on the point about maybe using technology to empower people to do more for themselves. What's your thoughts on this as we head into a difficult period for us all?
Yeah, you know, I think I was thinking about this question and listening to everyone else. The thing that struck me is, certainly as a layman, is the need for really coherent and really kind of robust public health approach in terms of the ways in which, the messaging, the kind of instructions and guidance are delivered to the population, to the whole of the country, have been good, bad, pretty bad, and this idea, how can we take what was working really nicely and just build on that? And that, I think, is something you can build on in a wider sense, not just about the pandemic, but in terms of certainly there's some really great work around taking a public health approach to end-of-life care, which is the area I work in, and that's a really kind of a powerful way to kind of unlock the natural capacities of communities around the UK to kind of support and help each other through incredibly difficult times. And there's lots of great initiatives, there's loads of great evidence, loads of great research that shows that this is a totally viable way of kind of cultivating care. And I think that's, for me, that seems to be the kind of underlying way to kind of to weather the storm, and also kind of build on successes of the mutual aid groups that kind of sprung up when the lockdown emerged, when it began. And, that can be supported through technology. But a lot of the best stuff was just literally putting a green or red card in your window saying, I'm okay, I'm not okay, or it's literally handwritten notes through your door. And so there's a role for high and low tech. I think as the kind of complexity increases, the Scottish government and the British government finally released the kind of contact tracing and sort of Bluetooth enabled apps for kind of test and tracing, which is like a really good example of like how technologies can be quickly used to kind of piggyback on the thing that most people have, which is a smartphone of some sort. Like, how do we use that technology to really kind of give ourselves a bit of an upper hand to a very kind of to a virus, basically. So that's kind of, those are good examples. I think underpinning that all though is the kind of idea that we all live inside a community, and how can those communities be robust and healthy in themselves to allow those who don't have phones, those who aren't confident using technology, those who are more isolated to kind of not fall off the map, because that's the thing that really terrifies me.
And leading to that, you're talking about healthcare apps, and I just want to bring in a question from the audience. This is from Ellie, and she's asked that there are all sorts of healthcare apps out there. So which ones do you think are the best for people to help themselves to help you?
Well, I mean, my first protocol is, the NHS has done a really good job to curate, evaluate, and promote a number of healthcare apps and services through the app library that they have. So that'd be my first protocol, because that is a really great way of basically knowing that anything you're going to use is being tested and checked by the NHS. On top of that, there's any number of really kind of interesting, community-led, kind of community-centered apps that Nextdoor's, more of a website, but a good example of how, you can kind of quickly build very local infrastructure digitally that allows you to kind of tap into the kind of needs that communities have, because they might not always just be, kind of clinical health problems. It might be social health problems, and that can be ameliorated through social contact and kind of community building. So that's where I'd go.
Has anyone else got any thoughts on that question, or no? Okay. My next question for you guys is, how important is it for us to provide coordinated care for patients across medical, social, and community care? And how are these relationships tested during the outbreak? And what have we learnt about joined up care during this period?
Well, I might dive in at that point. I mean, I think that there are some fundamental principles to strong primary care. That there are core principles like universal coverage, the fact that every person can access care at the point of delivery, that it's cradle to grave longitudinal care. And one of the very important third pillars is comprehensive care that's holistic. It considers not just the whole person, the whole community, over generations. And a big role for the general practitioner and primary care teams is to be coordinators. So we're the gatekeepers. People will come to us often first, or they'll go to emergency departments and then be sent back to their GP. But we do an awful lot of coordination. It's absolutely essential and critical. So we need to do that, not to ration care, but just to make sure that the people that need to get to hospital services do that. And where that goes wrong, where there isn't accessible care, I've shown this in my research, it's very sensitive to patients walking to emergency services, and you get this sort of cycle of consulting and reconsulting, and it starts to break down and fall down. It's also really important, and this may be better for Anna to pick up on, but you know, when you're thinking about discharging patients back into the community, don't send them out into the community and forget to tell us, because there will be no one to pick up the pieces. We need to make sure that we talk to each other, that, you know, it's safe for patients to go back. If you've got someone who's elderly, has had to go into hospital, you need to make sure that there's food, that their cat's looked after, that, you know, that people, their relatives know. And actually general practice does a fantastic job there, because we will have usually not just the patient's record, but we will have now quite a lot going on. And what we've done recently, it hasn't quite been realised, but we've been all working very hard on Coordinate My Care, which is a system where patients can agree or say how much, what level of sharing they want of their personal record. But in the event that people have complex care in particular, it can be very helpful where other agencies can have access to certain levels of information. And that can be a lifesaver. It can keep people safe at home, out of hospital. It can make sure that their wishes are observed when they're too ill to sort of communicate that. And we found where it works is in end of life care. It's actually very useful. So we need to bolster up some of those systems. They're not quite fit for purpose yet, I think.
And Anna, you know, Sonia gave some fantastic examples of just the importance of that joined up approach. It'd be good to get your thoughts.
So there'll always be a part of me that will be thankful in some ways to the gods or whoever created COVID, because this last 6 months has, that was possibly not the most sensitive thing to say. My point being is that the pandemic has catapulted the concept of joined up and coordinated care into the future that I've been trying to build with my teams and my colleagues for some years. And what we've learned, just to come back to your original question about how relationships have been tested during COVID, well, I think what we've learned is that where relationships between hospital practitioners and teams and primary care were strong before the pandemic, those areas have been able to innovate in the most unbelievable ways. Where the relationships were just starting out or less strong, it's been harder to innovate. Not impossible, but definitely harder. So what that means is that looking forward, we've got to have a really deliberate focus on building and maintaining personal relationships. It's not just, I think, probably not just professional relationships. It probably goes one stage further. And what that then engenders is organizational trust. And, you know, working at an organization like Imperial, which is always considered to be a risk for sort of taking over and gobbling up other organizations, the concept of organization and corporate trust feels really, really important. The other thing that we need a really deliberate focus on is an unapologetic and single-minded view about doing the right thing for the patient, even if that means ceding power from ourselves, from our teams, from our organizations, or giving up money, or all of the things that drive human behaviors, and being very, very single-minded and jointly focused in a very mindful way on the right thing to be done for the patient. And the third aspect that I would point to is building a culture of curiosity and humility, which is not always easy when you work in a big teaching hospital. But role modeling that as leaders, I think, again, brings about an environment in which those trusting relationships can be built. So the example I want to describe to you is in, as Sonia mentioned, the problems that we sometimes have in safely discharging patients from hospital. So one of the things that COVID gave birth to was the concept of hospital discharge hubs. Now, previously, discharging patients from hospital was completely the responsibility of the hospital, as you know, that sounds logical. Now, what happened in March was a diktat from the Department of Health that our community providers should be parachuted into hospitals to coordinate hospital discharge, which when you first look at it, you think, what is the logic in that? And those poor community leaders who had to, you know, be shoved into that sort of rather difficult coordinating role. But it has been really extremely beneficial. And what we now have is co-located on each hospital site, a power team. I think we've got one of my favorite photos of the last 6 months, which I think we can bring up, shows this. Here we go. It's the ultimate girl gang. So this is the Charing Cross Discharge Hub. And in this photo, you've got a hospital consultant, hospital therapists of various different professions. You've got community healthcare providers who are sort of leading this group and coordinating it. They happen to be therapists by background, but they, you know, they could have been nurses or not at all. You've got discharge coordinators who are managers, case managers. You've got mental health professionals. You've got adult social care, so local authority employed reablement and social work specialists. Now, if this team can't get a patient, even with the most complex care needs after their acute episode, safely to the best place for them as quickly as possible, no one can do it. And we didn't have that before. What did we have? We had streams and streams of emails. Emails do not discharge patients safely. And behind the scenes of all of this is we've got the relationships, as Sonia mentioned, most importantly with the GPs, to make sure that anyone that's going home with a package of care in their home, or is perhaps going to a care home or a homeless shelter, or any, let's say, non-standard discharge pathway, that their GP is absolutely connected in and able to follow through their care once their hospital episode is over. So all of this has enabled us to really utilise the hospital bedded capacity, which has been, you know, at an extreme premium during the initial wave of the pandemic, but will continue to be because hospitals are never going to have enough beds. It means that we can use those beds for those who are acutely unwell and really need that clinical care that can only be provided in a hospital, rather than lingering in a hospital because there's a difficulty in getting them elsewhere, which has, you know, terrible downsides for patients. You know, it is not a risk-free environment to remain in hospital longer than is necessary. We know that patients don't want to stay longer than is necessary in most cases. And it's not the best use of the taxpayers' money. So all that to say is that none of that would have been possible were it not for the human relationships that underpin it.
And that's a really strong example of building and maintaining that relationship. And you talk about organizational trust. Do you think, you know, with your example that you've just shown here, do you think that's something that can be a reality as we within, you know, will it take time, do you think, to build that and maintain those relationships?
I think it depends on a variety of different things, but I definitely think this has leapfrogged us into a future that, as I say, I've always, you know, dearly hoped for. I think coming back to our earlier discussions about the political sensitivities and the personal sensitivities around reallocation of services and, you know, delivering services between hospitals in a different way, that causes high emotion in the public and in all groups. So there'll be bumps in the road, but this has taken us a good few steps forward.
Great, thank you, Anna. Ivor, this is a question for you, and I think we've touched upon the use of healthcare tech and how important it's been during this pandemic. So from your perspective, as we look into providing quality care in the future, what do you think the role of technology is when it comes to general healthcare, and looking long term, you know, 10, 20, 30 years down the line, what do you think is the role of technology?
Yeah, I mean, I guess the the idea of kind of future casting, the potential of technology into 10 or 20 or 30 years is increasingly not difficult, but it's quite amazing. If you think back, if you think 30 years ago, it was 1990 that Tim Berners-Lee created the World Wide Web. So if you think about from Tim Berners-Lee at CERN in Switzerland creating what became the internet in 1990, and what everything has come after that. If you think about what the internet has done to our world in those 30 years, you get an idea of the scale of change and difference that another 30 years will create. So you have, and I think about, well, what's the internet done? So let's just think about that. I mean, in terms of healthcare, the obvious one is that anyone can look up anything and see papers, can connect with other people, can kind of read up on conditions or diseases or anything that they might have going on in their life. And I'm sure, Sonia, you've had many a patient turn up in your surgery with printouts of, WebMD and Google, et cetera, et cetera. And I find that really kind of, I mean, I've done it, to be fair. There's a flip side. One is that idea that, knowledge is available. And I think in going into the future, all that knowledge that is available will then become organized in a way which is more appropriate and more personalized and more attuned to that person. So it's one thing to present all the information, it's another thing to make sense of it, which is where AI comes into, which is around as much about pattern recognition as anything else. But on the flip side is basically what happens when humans and technology meet. Well, it can bring out the worst of us in terms of, these technology patterns can be in a way weaponized to exploit human frailty and the kind of behaviors that we have. So searching the internet brings a lot of anxiety to people because they suddenly think that they might have something that they might not until they actually get tested. But the flip side is that you're empowered by it. So the patient can become the expert because they have, hours, weeks, months to really kind of understand a bit more what's really going on inside them. Whereas, clinicians and healthcare teams have got limited time. So there's an opportunity there for them to be kind of alongside the person with their healthcare needs. So I think if we think long term, it's both the kind of refinement of technologies. It's how things will slowly increase. There's obviously the big dramatic things that the Elon Musks of the world love to talk about, where we're going to have computer links into our brain, and we're going to be flying around in jetpacks, all that kind of stuff. But then again, there's just the real basic stuff, which is what happens when you get reliable, fast internet to lower and middle income countries. What happens when you get fast, reliable internet into rural settings in the UK? That kind of real basic piping of infrastructure stuff is still what needs to happen over the next 20, 30 years. And that will just make everyone's experience a lot better. So those are the kind of things I think about on top of the kind of more science fiction stuff, which admittedly is already here. If you think about what Apple is doing right now in terms of their Apple Watch, in terms of the miniaturization of healthcare kind of diagnostic features of a watch, I mean, is incredible. Even 10, 15 years ago, you'd think that was pretty wild. So that kind of stuff, you can it'll be more of the same. I mean, as William Gibson said, the future's already here. It's just not evenly distributed.
And that's that's a really good point about talking about even distribution. I want to bring in a question from our audience. This is a question from Julia, and she says, I can see how technology can continue to transform the NHS, but how do you deal with digital poverty to stop further inequality? So, not everyone has access to internet, smartphones, computers. How do we deal with that?
I'm going to just give you a really sorry example of that. So last week, I saw a single mum who's really struggling with her asthma. Her young son had brought back a virus. We think it may be COVID, we're not sure. She'd run out of inhalers. She's completely isolated and she's completely lost. Now, she doesn't speak English. I don't think anybody's really thought about how we're going to get through to people who are not only digitally struggling with digital literacy, people like myself, but you know, we really haven't addressed the needs of people where English is not your first language. It's completely inappropriate for her 4 or 5-year-old who is actually quite digitally literate to be trying to sort of order her a COVID test. So I had to get on my bicycle and go and see them sort it out. But again, it comes down to that coordination of teams that Anna was saying. And I think that one of the things that we really need to do is also get away from this this blindness that we have. We think that we know the answer, but there are communities out there who actually have come up with amazing solutions. We can learn actually with a lot of reverse innovation literature that shows us from places like Brazil, actually, that you know, if you look at simple things where there are low and middle income countries where they've had to think about non-expensive, very cheap, non-digital solutions, they could be the things that you could then incorporate into care pathways. So I think we shouldn't be driven by technology. It should be a tool for us to have a very important ethical principle. What is it we're trying to achieve with the health service, and who are we trying to achieve it for? Are those people given a voice? Are they really telling us? Are we really consulting them what they need? And so much of the NHS was built and has been built around the needs of the providers. And it's fully endorse what both people have been saying, both of our experts have been saying, that, you know, we need to design it with patients in mind. We need to get them into the conversation. So digital poverty is one element of it, but inequality is so nuanced. There's so many intersections. And one of the biggest problems with the whole response to this pandemic has been that there's been a blindness at the top. There's a very small group of people who are blind. There is no general practitioner on the stage. There are very few women. There are very few people of colour. And they cannot, you know, so you're going to come to the wrong conclusion. You can't make good decisions about people if you have no lived experience of what people's lives are like. Earlier, Matt Hancock was saying that when the vaccine comes, we're going to train pharmacists and nurses to give vaccines as well as GPs. Well, we've been doing that for years. Why don't you know this? You know, why? And the mismatch, the misdirection is occurring because the people who are in decision-making positions are not able to understand what inequality is driven by. They've really got to educate themselves.
And I think one way of doing that is really understanding and engaging with the communities most impacted, I think. And I mean, that leads quite nicely on when we're talking more about inequalities. I think we can all say, this pandemic has really shone a spotlight on the racial health inequalities, especially for ethnic minorities in terms of outcomes and the experience of this horrible virus. And also this summer's Black Lives Matter protest has also shone a spotlight on systematic racism in institutions, and that includes the NHS. I mean, how do we even begin to address systemic racism in the NHS and that affects Black and other ethnic minority groups?
Well, again, I'm going to jump in because you know, absolutely, you know, there have been good things that have come out of the pandemic, and one of the, I think, good things is that, you know, when you shine a light on a problem this vast, you cannot ignore it. We're all captive, and we have seen this, so we know that, you know, exposure has a huge amount to do with it. To start with, the dialogue was all around, well, it's all their fault for making poor lifestyle choices and having bad genes. And that clearly is not the case. You know, we are exposing huge occupational exposures, healthcare workers, pregnant women, much more likely to be from a Black minority group and admitted to hospital. And so I think what's come out of that is that we now in the workforce have a new commissioner. We have a dedicated task force. So we have Marla Rao, who's actually one of our colleagues at Imperial, who's going to be leading that commission to look at race equality issues across the workforce, which we've never had before. We are going to be widening. We're going to have to address these inequalities. We're going to have to do much more outreach, and we're going to have to train the workforce and educate the workforce. And that's one of the things that I have called for. So I think we do need to think about really clearly monitoring both the workforce and health inequalities much more closely. And one of the big problems is that primary care and public health are very disjointed, because public health is now sitting inside local authority. So this needs a bit of a public health response. So there isn't an overnight solution to it, but we have started to shine a light on this, and it will out now, which is good.
And Anna, from your perspective, from a staffing level within the NHS, ethnic minority staff have been impacted by this. Unfortunately, there's been a number of deaths. What's your perspective in terms of how do we address this?
So I can offer a brief answer from the perspective of how our organisation is approaching some of this very big issue, and we're sort of trying to chunk it up into different sections to be able to resolve it. I mean, one thing that you mentioned earlier, Maxine, is how do you educate a white privileged organisational leadership? In our trust, we're trialling the concept of reverse mentoring, whereby each of our non-BAME, so BAME being Black and ethnic minority colleagues at the top of the tree, are partnered up with BAME colleagues from different layers of the organisation, and they spend concentrated time together to share perspectives. And I understand from colleagues that have been through this, it genuinely changes the way that they approach decision making and problem solving, just having a different perspective offered to them that challenges their own sort of standard way of thinking. So reverse mentoring, I think I'd love to see that rolled out across a much wider staff group. I'd love to take part in such a thing personally myself. Another thing we're doing, again, these are small sort of tactical things, but making sure that when we're recruiting into new posts or into vacancies within the trust, we're being extremely mindful of how those opportunities are advertised, and making sure that white privileged networks aren't used in any sort of nepotistic way to over advantage certain groups and accidentally disadvantage others, even if it's completely unintentional. Making sure that every recruitment panel has a BAME representative on it, so that people who are going for jobs can see that there are people that look like them, and that might help them to perform differently in that setting. So they're small things. We don't know yet whether they'll make a difference. Those are only a few examples of a much wider race equality improvement project that we've got going on. It is one of our 4 focused improvements for this year, so that's how central it is to the trust.
And Ivor, I mean, I know it's a bit of a, I don't think there's like a technological solution to solve systemic racism, but is there anything you could add from your perspective in terms of how it could contribute in some way?
Yeah, I mean, as almost every other place in society, this is kind of been a kind of a revealing time. And I think from my industry, in terms of design and technology, has historically been people like me. It's been white middle-class men designing things. The role of women has always been underplayed. It's been historically suppressed. The role of minorities has been sort of suppressed as well. I mean, when you start to dig, the largest major technological leaps in the 20th century were often by females, often from minority backgrounds, and NASA was built on the backs of mathematicians from who are African Americans. So there's one thing which is just to reveal the reality of things, and I think that's may have happened to a certain extent. And I think one sort of powerful effect of the pandemic has allowed everyone to viscerally understand that we are all interconnected, that there's a network of that runs through everyone, and that, you know, there's no way to kind of make distinctions. You know, we're not separate from each other. And so that has a powerful way of kind of shining a light on just how different and so how big the stark inequalities can be. I think, yeah, there's no quick fix to this kind of stuff. And I always think about the quote, like the master's tools won't dismantle the master's house. So I kind of wonder, you know, where the kind of the mechanisms for change can genuinely come from, because it certainly can't come from government. It certainly can't come from the institutions that themselves were built on the inequalities that still exist today.
Can I give an example of what you've just said, Ivor? I think it's a really lovely example, actually. We might even have a picture of this. So what you said is that women have designed wonderful things. It's a simple idea, but in the beginning of the pandemic, we were not able to get any PPE at all in primary care, so we kind of made our own. We then went to a position where some of the masks arrived, and I posted a picture on Twitter showing me with this enormous mask on, sweating away, and a big gap on either side. This is a man-made mask. I'm a small Asian person. None of that was any good for me at all. It was the local Muslim ladies who made this beautifully stitched mask, and you can see how it just fits me perfectly. And they thought about that. They came along and they measured us, and we've got these gorgeous scrubs in different colours. And I think there's another picture as well where I show my new tools on Twitter. And in that, so just lovely from the Ahmadiyya local mosque. They built the mask, and so it takes women to really understand who's going to be looking after them, and they gave all their time for free. So I think, you know, it illustrates the point that we have got to get designers like you to be more diverse. We've got to get people in decision-making committees to be more diverse, and patients know what their needs are, because they're the patients. Stuff like that concerns them the most. So we've really got to find ways of involving people much more and empowering them to take control of their own care.
And just finally, I want to bring in the audience into this, but you talk about, you know, the pandemic and the response to it and the issues it's raised. It's quite clearly like the changes that need to be made. From your perspective, this is an audience questions from Remia. What changes made during the pandemic do you think that should be kept, and why? I'll open that up to you all.
I'm happy to kick off with that one, Maxine. For me, it's got to be the dissolution of the red tape. You know, this pandemic has done away with huge amounts of bureaucracy. I'll give you an example. So for patients who are being discharged from hospital into nursing homes, or sometimes going home with some home care, and they're in a precarious situation, and they need a fast solution to this. They need to get home quickly. There was previously a process of commissioning teams coming in and assessing the nurses, assessing them in the hospital, which could take some time based on the nursing team's availability. Then they'd have to take that assessment away and work out what provider could be matched to the patient's needs, all the while the patient's, you know, merrily, potentially deteriorating or coming into contact with risk. And of course, they're not being assessed in an environment that is representative of how they would function after their hospital episode. People function differently in hospital than they do in their normal environment. So quite often the assessments then have to be redone because they're not accurate, and, you know, all sorts of shenanigans that would wind up with patients staying longer. And all of this because it's the commissioning teams that were holding the budget for those placements or those care packages. So COVID came along and the rule makers said, forget that, we're going to catapult you into the future of something we've been working towards for a while, known as discharge to assess. So the basic concept is no permanent placements are made from within the hospital. Put someone into a nice, safe interim placement, they're assessed there, where they're in a much more representative environment of what their future function would be like, and the decisions can be taken from that point onwards with a sort of 6-week review. And because the money and the decision making was put into a wider group, and health and social care were allowed to work together, and taking away that it's my money, it's your budget, you know, I'm doing it, you're doing it, things over the fence, it really has improved the way that discharge pathway is managed. It's better for patients and it's better for the staff that work on those pathways. So for me, it's got to be dissolution of the red tape and keep it that way.
Sonia? I think. Sorry, Sonia, you're on mute.
Classic mistake. You see, technology, we need training. I just think that ultimately it has obviously, like with wider issues, made everybody re-evaluate what they value, what they really value in life, and it's really helped people value the NHS. I really think that that was the case, and even though the clapping has stopped in those first early weeks, I think a lot of people are going to remember that for a long time. And I think that, you know, we are valuing all the elements of the health system, not just the doctors and nurses. We need to back that up with, you know, really rewarding them in real terms. But again, my Muslim ladies know who, you know, it's helped our relationships in the community. They're the people who have really valued the care that we've offered. And so for me, it's about the whole of society's morality, moving away from constantly selfishly making money and thinking about what do we really need. We need to be healthy, we need education, we need each other, and we need a nice clean environment to live in, and I think that we're all thinking about how we can achieve that and align economic, climate and health goals, and bring them all together into one.
And Ivor, finally over to you. From your perspective, what would you keep?
I would keep the role of community. You know, in terms of it may have gone from a nice to have to a need to have, and I think the role, if we can keep that in place, that spirit and that kind of cooperation in place, that will allow us to unlock new models of care that, you know, are waiting in the wings, to help, you know, really help us with the next spike, the next pandemic, the next whatever it is that comes around the corner. I think that will allow, you know, the NHS and health services to, you know, get back to what they're really good at, and actually allow the communities who really can help support each other be allowed to do that and be supported to do that. And I also just think that we should keep the demand for high quality care for everyone. I think it's just showing the disparity, the shocking state of care homes and the way in which they've been treated by various places is testament to the idea that we demand better and we want better. And I hope that stays, and I hope that demand for that type of care will remain.
Brilliant. Great. Thank you so much. Unfortunately, time is up for tonight's discussion. I think we've gone over a few minutes, but that's testament to such great answers and fantastic discussion. So I just want to thank you all. I want to thank our speakers. So thank you, Sonia, Anna, and Ivor, for what was a really fantastic discussion. And I want to thank the audience, for everyone who's joined us for this live conversation. For those watching on YouTube, apologies if we're unable to get to your questions. We had quite a few. Sorry about that. And a recording of this discussion will soon appear on YouTube, on the college's YouTube channel, so you can watch it again, share it with your friends or colleagues if you want. A link will soon be posted in the chat for an evaluation form. So if you can tell us what you thought about the event, that would be great. Your feedback helps shape the delivery of the programme and the content, so having your insights is really helpful. Other than that, that's it from me. So I want to thank you again for tuning in, and have a good evening, everyone.